Continuing on with tapentadol or Nucynta. So it is a mu receptor agonist, not as strong as a true opioid, but stronger than tramadol. So it is about as potent, though, and some may disagree with this, but there's evidence to show from clinical trials, bunion surgeries, and things like that, that it is about as potent as morphine. So a lot stronger painkiller than tramadol is. And so the reason it is able to be that potent but be a less potent binder at the mu receptor is because it is a reuptake inhibitor, a fairly potent reuptake inhibitor of norepinephrine. And that extra amount of norepinephrine seems to make up for the lesser degree of binding to the mu receptor. So bottom line is you still have a risk of respiratory depression and CNS depression that you do with morphine, but you have a less of a propensity for it to cause constipation and the typical opioid-related GI side effects. Anywhere, depending on the study you read, anywhere between a 15% and a 25 to 30% lower incidence of GI side effects. So really the only niche, the only rational reason for prescribing this drug would be in a patient that is you are very concerned about constipation or the GI side effects, and you'd like to have a drug that has less risk of causing those side effects. Nucynta ER that's available now for chronic pain makes even more sense for some patients who are going to be taking an opioid every day and are certainly going to have issues with GI side effects and some constipation. So this doesn't help every single patient. Again, it's only between 15 and 25, maybe 30% less incidence of GI side effects, but it is better than morphine for some patients. So that's this drug's niche. As effective, maybe, as morphine, but a better GI side effect profile. No real other niche for this drug, and it's just as much risk of CNS and respiratory depression. So the use of opioids in chronic pain. If you read that VA article, you want to run across this kind of a summary where they recommend that a trial of opioid therapy for chronic pain is indicated for patients who meet all the following criteria. Of course, they have to have moderate to severe pain that has failed to respond to non-opioid and other non-drug therapies, where of course we think that the benefits of opioid therapy are likely to outweigh all of the risks. And the patient, of course, has been fully informed and consents to long-term chronic opioid therapy. And very importantly, that there are clear and measurable treatment goals established before therapy is begun. What are we trying to, what is our goal in treating with opioids? And so once we start a trial with chronic opioid therapy, if we're not meeting that goal, we can stop the therapy. So this is where they recommend chronic opioids should not be initiated. These following situations. If somebody, of course, has severe respiratory instability, they're not a good candidate for chronic opioid therapy. In patients that have psychiatric instability or uncontrolled suicide risk. People that have a substance abuse disorder that's not in remission, or these people are not in treatment. People with a true opioid allergy. Most patients that say they're allergic to opioids are not allergic to opioids. Morphine and many of these other drugs can cause a histamine release that can cause itching and a rash, but that's not an allergy to the drug. Co-administration of interacting drugs that could cause life-threatening interactions. If the QTC interval is greater than 500 milliseconds and the patient is to be put on methadone, that's a contraindication because of risk of arrhythmias, torsades. And of course, if somebody is engaged in active diversion of controlled substances, not a good candidate for opioid therapy. Here's some conditions where we may initiate therapy, but with great caution and probably with specialist involvement. Somebody with COPD or mild or moderate asthma, somebody that has obstructive sleep apnea without CPAP, somebody that has a suspected paralytic ileus, somebody that's to be placed on methadone and their QTC is 450 to 500. You may use the drug there, but with great caution and getting periodic EKGs to see how they're doing or what their QTC interval is. If somebody is in treatment for substance abuse, you may consider putting them on chronic opioid therapy, but of course with great caution and monitoring. If somebody is cognitively impaired, they're going to be likely non-compliant, then great caution, but not an absolute contraindication to chronic opioid therapy. People with unstable psychiatric disorders that are at suicide risk, and people with complicated pain like headaches, where you have to use great caution in prescribing opioids because they're generally not as effective as other therapies are, and can actually lead to rebound headaches, and so you can get into a very complicated situation. Much better really for headaches as episodic, not chronic therapy. I'll let you guys look over these slides on the stages of withdrawal from opioids. Generally, unlike benzos and barbiturates, these are not considered life-threatening withdrawal. I'll let you read these couple of articles in past papers. There was an article in the paper today on Wednesday, or maybe it was yesterday. Yeah, I think it was yesterday on Tuesday about a fellow that was abusing OxyContin. Alright, let's talk about NSAIDs a little bit. There's really only a couple of points that I want to make with these. Number one is that there is no evidence that any particular NSAID is more effective than another, and believe it or not, that even extends to ketorolac, that a lot of people think is significantly more effective than other NSAIDs, but the evidence actually does not bear that out. What we do know about ketorolac is that it is very much more likely to cause ulceration of the GI tract and cause an ulcer. NSAIDs are analgesics, they're anti-inflammatories, and they're also antipyretics, as opposed, of course, to acetaminophen, that is an analgesic and an antipyretic, but does not have any anti-inflammatory properties because it does not block inflammatory prostaglandins in the periphery. It only blocks prostaglandins in the CNS. So, talking about prostaglandins, when we talk about the mechanism of action of NSAIDs, they do block, kind of broad spectrum fashion, the formation of prostaglandins. Prostaglandins are formed when arachidonic acid is released in response to an injury, and then that is metabolized by these COX enzymes, the cyclooxygenase 1 and 2, to form three types of prostaglandins. PGI2 is prostacyclin, and this is actually an antiplatelet effect from this prostaglandin. PGA2 is thromboxane, and is just the opposite, actually has a pro-thrombotic effect. And then related to pain, we have PGE2, which is responsible for the formation of a pain response, for fever, and is also responsible for gastroprotection. Cyclooxygenase 1 works to produce prostaglandin A2, which is thromboxane. It also produces prostaglandins that protect the stomach. So if we were to use a drug that blocks COX-1, we are going to cause the inhibition of platelet aggregation because we're blocking the effects of thromboxane, and we're going to allow for GI irritation because we're blocking the prostaglandins that protect the stomach. So if you combine those two together, you have an increased risk of GI bleeding because you're allowing irritation of the lining of the stomach and you're causing an antiplatelet effect. Cyclooxygenase 2 produces prostaglandins that cause edema, pain, and inflammation. That's PGE2. And it also produces prostaglandins, this one called prostacyclin, that inhibit platelet aggregation. They're essentially antiplatelet prostaglandins. So if we give a drug that blocks cyclooxygenase 2, we're going to reduce pain and inflammation, and we're also going to cause platelet aggregation because we're inhibiting prostacyclin. So if you look at this diagram here, we have arachidonic acid being released in response to a painful stimuli, and then cyclooxygenase 1 causing the production of thromboxane and prostaglandin E2, and cyclooxygenase 2 causing the production of, again, PGE2, which causes pain and inflammation, but also causing the production of prostacyclin, which is an antiplatelet agent. So if we give a drug that blocks COX-1 and COX-2, we see a reduction of prostacyclin, a corresponding reduction of thromboxane, and a reduction in PGE2, so a reduction in pain. But we keep this prothrombotic prostaglandin and this antiplatelet prostaglandin in balance with each other by blocking the production of both of them equally if we give a drug that equally blocks COX-1 and COX-2. But most drugs don't block these equally. If we give a drug like Celebrex or Vioxx or Bextra, the latter two are off the market now, then we are preferentially blocking COX-2 and not blocking COX-1 very much. So what happens here is we do cause a decrease in the pain response, but we block prostacyclin. By blocking COX-2, we reduce the amount of prostacyclin that is produced, but we're not blocking COX-1, so we allow physiologic amounts of thromboxane to continue to be produced. So now we are out of balance, and we are potentially at a prothrombotic situation here because we are blocking antiplatelet prostacyclin and allowing normal levels of thromboxane to be produced. And this is exactly why drugs that are potent COX-2 inhibitors, like Vioxx was, you actually see an increase in the risk of strokes and MIs because you've got an imbalance and a non-physiologic higher level of thromboxane being produced than prostacyclin. Most NSAIDs like ibuprofen and naproxen are non-selective, meaning they don't preferentially block COX-2 over COX-1, they block both. That's why people that are on some NSAIDs like naproxen actually see a net effect of an antiplatelet effect and increased risk of bleeding. When you block COX-1 and COX-2, you're inhibiting the gastroprotective prostaglandins, and so you can increase the risk of a GI bleed, but you're preserving that relative balance between prostacyclin and thromboxane, so you're not causing a prothrombotic effect. The only COX-2 selective inhibitor left on the market is called Celebrex, and it is the least COX-2 selective drug of the three that used to be available, Vioxx and Bextra being the others. As a result, Celebrex does not seem to be very prothrombotic, but it is also not very gastroprotective. The very large class study that came out to put Celebrex on the market showed that after 6 months of therapy, there was no difference from an endoscopic perspective of ulcers in Celebrex patients and in ibuprofen patients. During that first 6 months, we see a reduction in endoscopically observed ulcers.